Can you hear now?
Yes.
Oh, did you hear the introduction or did no one hear that? Oh
No.
my goodness, we're having technical difficulties. Let me then very quickly recap. Very sorry, can everyone hear me now? Okay,
Yes.
let's start again. Very sorry about that. Good afternoon, thank you for joining us. Today, our webinar will be presenting management of depression in people undergoing long-term dialysis. After his presentation last year, giving you the results of the study on dialysis patients, we asked Dr. Raj Mehrotra to return to go into more details on how to implement such a program in the dialysis facility. And given the COVID-19 pandemic, it is especially timely and relevant. Let me quickly introduce Dr. Mehrotra again. He is the professor of medicine at the University of Washington, section head of nephrology at Harborview Medical Center, and he's a physician scientist, and he does clinical research focused on improving symptoms experienced by patients treated with dialysis. As usual, for attending this webinar, one continuing education credit is available to all nurse and social work attendees who pre-registered. If you're joining by phone, please send your phone number to hcecil@qualityinsights.org so she can verify your attendance. And forms will be sent to you within a month of this event. And please post any questions that you have during the presentation using the Q&A icon at the bottom of your screen. We hope to answer as many questions as possible. I'll turn it over now to Dr. Mehrotra.
Thank you, May. Thanks for the opportunity to share my thoughts on this important topic. Let's see. I'm just gonna, what I'm going to try to start off with is, excuse me, why should we screen for depression in patients undergoing long-term dialysis? That will be a recap of what you may have heard earlier. And then go on to the practical aspects of developing an effective plan to manage depression in people on dialysis. We'll talk about screening and diagnosis of depression, and then developing a plan of care. My thoughts on how we go around overcoming barriers, selecting a treatment option, operationalizing drug therapy, or operationalizing cognitive behavioral therapy in the setting of somebody that is getting long-term dialysis. So why should we screen for depression? And I'll try to make a clinical case, and then there is the regulatory case, and I'll lay it out for you to be aware. The first thing is that depression is common. This has been studied in people on dialysis for the last 30 years. And studies have been done around the world using different ways to diagnose depression. As you can see, this study is the summary of all of those studies published 7 years ago. And these are a summary of almost 200 studies with almost 50,000 patients. And on average, depending upon how you diagnose depression, about 37% of people worldwide on dialysis would have depressive symptoms. So at any time point, 1 out of every 3 person on dialysis has depressive affect. So it is common. It may be particularly more important in the day and age that we're living in with COVID. People, of course, I tried to look hard for any data that we may have for the prevalence of depression during the COVID pandemic. And not just in people on dialysis, but people otherwise. And there is actually a lot more that has been published on the mental health challenges in healthcare providers, in physicians, in nurses. There is a very high prevalence of emotional distress measured in many different ways. We can look back in how patients on dialysis responded to natural disasters of the past. There are studies that have been published not for people on dialysis, but generally, for example, during 9/11, in terms of how it affected the mental health of people we take care of. This is during Hurricane Katrina, and this is almost 400 patients at 9 dialysis facilities in New Orleans, and they did phone interviews 9 to 15 months after the hurricane to assess the mental health of people. And as you can see, 51% of people had various combination of PTSD and depression. So that is much higher than the 37% of depression that has been shown in studies of the past. That natural health disasters, pandemics like COVID-19 is anticipated to worsen the mental health of people we care for. It may manifest not just in worsened depression, but also in greater anxiety. And as healthcare workers that are involved in the care of people on dialysis, it would be important for us to be sensitive to the impact of COVID-19 pandemic and then the social turmoil that has followed with joblessness and now a reckoning of race relations is probably all affecting the mental health and well-being of people we care for. The challenge in people that have depression is that it makes the difficult life of a person on dialysis harder. The disease itself and the treatment impose a lot of demands on people that they have to do. They have to show up for dialysis 3 times a week. They have to take all of these different medicines. They have to restrict their diet to be sure that they're not taking too much potassium, too much phosphorus, too much fluids. And then they have to get a transplant evaluation. They have to look for transportation. They get hospitalized, they're discharged. It's a difficult life. And when you are depressed, it makes it harder for people to do what they need to do. I just don't want to just point out to this number 3.44. Essentially, what this study, this is a summary of all of the studies, and essentially it is saying that in people that are on dialysis that have depression, they are 3 times more likely not to do what they're supposed to do. So that if they're supposed to show up for dialysis 3 times a week, they're 3 times more likely not to show up 3 times a week. So it makes it difficult for them to show up for dialysis, for them to complete the full treatment, to take the medicines as they prescribe, or adhere to numerous dietary limitations. So if you're a nurse, if you're a technician, if you're a nephrologist, if you are or a dietitian, and you're dealing with somebody who's not following up on what they need to do, be mindful that they may have depression. Be certain to be sensitive to that and look out for that because that is a manifestation of that. And because people don't do what they're supposed to do, they have a higher risk for death. Not only is it common and it has bad effects on people's health, there are effective treatments for depression. This is the study that we completed in 3 different areas in the country in which we looked at 2 different types of treatment, cognitive behavioral therapy and drug therapy. And I'm not going to talk about right now the comparison between the 2 treatments other than the fact that depression scores decreased. That means people got better with both treatments. And between 1/3 to 40% of people had a significant decrease in depression scores in response to treatment, and many of them completely got better. So what I've tried to say is trying to make a case, there's a clinical case for us to have a unit-wide plan for managing depression because it's common. It causes a lot of suffering. Treatments work, albeit they may be less effective than in the general population, but we can reduce suffering by providing treatment, and then it's the right thing to do. There's also a regulatory need for us to be screening and following up for depression. I'm not going to go through each one of these items that is listed on the table. You may know that Medicare judges the quality of dialysis units and in a way that it affects the payments that are made to the dialysis unit for dialysis. And it's the QIP program. And there, as you can see, there are 14 different metrics that the quality of care in a dialysis unit is judged. And one of them is whether in what they're doing for screening and follow-up for depression. It is, in the regulatory lingo, it is what we would call a process measure. So we're not looking at how well the units are doing in improving depression. But essentially the unit has to certify that there is a process in place for looking out for depression. You just have to report what you're doing for every patient. Is the patient eligible? Did you screen them? If you screen them, was the screen positive or negative? And if it was positive, did you develop a plan of care? You can get full points for the measure, even if you didn't screen anyone. You can have 100 patients in your dialysis unit and you said, I didn't screen anyone. And that will meet the requirements for the process measure. It'll be sad if you do that, but from my standpoint, but you can do that. And if you screen and you have the results and you did nothing with it, you would still get full points. The expectation of the nephrology community is that this process measure will become a clinical measure, that units will be judged on what they do. So right now you just have to report what you're doing. Tomorrow it could be that they'll change it and they'll say, hey, no. How many of those, we will treat you, we will give you credit if people that you identified that had depression got better. And in fact, in the new, you may be aware that CMS has released these voluntary kidney care models. These are models for value-based care for people on dialysis and with stage 4 and stage 5 CKD. There are 3 measures of quality that are included in these voluntary kidney care models. And if you look at number 2, it's remission of depression. This is that clinical measure that I was talking about. In these value-based care models, CMS has moved on to the next step, that it is not enough for us to be screening for depression. It's not enough for us to be having a result without a plan. We want you to implement treatment for people that have depression, and we want you to show us that they are getting better. For us to believe that you're a high quality dialysis unit or a high quality kidney nephrology practice. So I think it is important, the regulatory case is as important. So I've already talked about the clinical case. It's common, causes a lot of suffering. There are effective treatments, but there's also the regulatory case that Medicare requires us to report if we are screening or developing a plan of care. It's a part of a metric that Medicare decides if they will cut our payments by up to 2%. And I've already talked about this being a metric for value-based care models for kidney care. So hopefully I've convinced you so far that screening and developing a plan for management for depression is important, and we have to do it. The next step is, how do we go about doing it? And I just want to acknowledge my colleague, Dr. Sukar, who is a behavioral scientist in New York. This is a metric that he kind of put together that tells us a sequential approach to developing this. The first step is for us to identify patients with low mood, for us to be able to diagnose depression and then institute a stepped care management. There are comorbid conditions that need to be treated. And once we have a plan for treatment, that's not enough. Once the treatment is completed or we're towards the end of treatment, we have to evaluate the outcome and prevent them from relapsing and have a plan for ongoing monitoring. So I'll just start off with focusing initially on how to identify patients with a low mood and to have us diagnose depression. Now, the formal way to diagnose, so depression is actually a colloquial word. There is no, within quotes, a disease called depression. The formal phrase for the most common form would be what's called as major depressive disorder, or MDD. And you can go through this DSM manual, and there is a list of criteria that is necessary for you to diagnose depression. I'm not going to go through these criteria. It is important for you to know. I think there are two important takeaways from this slide. The first is that there is a formal criteria for diagnosis. There's a list of 9 symptoms, and somebody has to have 5 out of those 9. The second important thing is that those symptoms have to be present nearly every day for 2 or more weeks. I think that important time period of 2 or more weeks is very important for us to be aware of. So general characteristics of major depressive disorder are these 3. And I think if I can get the point across for these 3, that will be, I would feel that I've succeeded in communicating this message in terms of the diagnosis of major depressive disorder. There has to be a depressed mood in which you just ask the person, are you feeling depressed? Or there's a loss of interest or pleasure in daily activities for more than 2 weeks. This mood represents a change from a person's baseline. There are people, there's a lot of science, a lot of work that's been done in science of happiness, and some of us are born with an approach to life of the glass half full, and some of us are born with an approach to life with the glass half empty. The fact that in diagnosing depression, it has to be a change from a person's baseline acknowledges that reality. But it's not enough for somebody to feel low. It has to result in impaired function, whether it in a social setting or in their jobs or in their education. It has to result in some impaired functioning. It is challenging to diagnose depression in patients undergoing dialysis. Many symptoms overlap with symptoms of kidney failure. And that is why we need a screening program, because symptoms such as loss of appetite, feeling tired, are common in people on dialysis, even in the absence of depression. And it requires skill to be able to diagnose depression in people that may have other reasons for having these symptoms, like kidney failure. So how should we do it? I think it is important for us to be screening. We have to decide for a dialysis unit which screening instrument should we use, who should administer the instrument. When we administer the instrument, how do we interpret the results? And then what should the next steps be? So I'm going to address each one of these. This is a very partial listing of different instruments that are available to screen for depression. I think the one that is used most commonly, at least in primary care, and is now embedded in many electronic medical records, is the PHQ-9. And then there's a PHQ-2, which is a patient health questionnaire. There are others that I've listed here. I'm not going to go through them. This is only a partial list. There may be at least 10 others in terms of different instruments used to screen for depression. What most dialysis units in the United States use what is the PHQ-2. PHQ-2 is 2 questions, and the first question, so the stem is, over the past 2 weeks, how often have you been bothered by any of the following problems? The first question is little interest or pleasure in doing things. And second is feeling down, depressed, or hopeless. I just want to quickly go back to the slide that I showed you. There's essentially is the first point here, that depressed mood or loss of interest or pleasure in daily activities for more than 2 weeks. So this first point that I have for the diagnosis of depression in PHQ-2, it breaks it down into 2 different questions. And it is asking people to tell them that they have little interest or pleasure in doing things, or feeling down, depressed, or hopeless. And they ask people to rate it on a scale of 0 to 3 for each one of those questions. based upon not at all, several days, more than 1/2 of days, nearly every day. And so the range of the total score will be from 0 to 6. So I think in most dialysis units, at least I've talked to, it's the social workers that are doing the administration of screening. And I think that's the most appropriate personnel to be doing the screening. It is important for those of you that may be doing this already know this, but for those that you're not, I just want to call it out, that many patients will need help. Many of the patients that are on dialysis are blind, or they have other visual problems. Others have problems with dexterity. They may have neuropathy and they may not be able to, or they may have had a stroke and they may not be able to hold a pen to be able to complete that. And the point I want to make in acknowledging that, it's all right for the facility staff. So if it's a social worker that's administering the questionnaire, it's all right for them to read the question and ask patients to respond. When doing that, it is important that the question be read exactly as it is written, so that we as individuals shouldn't use our own words to paraphrase the question. It should be read exactly word by word in order the words are written for the results to be valid. There will be some that require instrument in a language other than English, and PHQ-2 has been validated in other languages. And I suppose that those of you that are in units where people speak other languages, you may have instruments in other languages that you're able to use. Just be sure to know that they're available for us to use them. And the final thing is, what's the standardized frequency of administration? In terms of what Medicare requires, it requires it to be administered only once a year. I think once a year is a bare minimum. It's probably the frequency of administration needs to be at least twice a year. In addition, it may be necessary for you to administer this around change in clinical circumstances. As I'm thinking about this while talking right this minute, is that there are these care plans that we do once a year, and then there are care plans that we do when people are unstable. And so one easy way to approach this would be if you're doing care plans for the times person is unstable, it may be good practice for you to use that opportunity to also administer the PHQ-2 again, to make sure that we identify people that may need help in a timely manner. So what do we do with the results? We've already said that the score could range from 0 to 6. What is significant is a score of 3 or higher. And I will just have you focus on this issue of where the prevalence is 18%. As you can see, that 60% of people with depression will have a score of 3 or higher. If you find somebody who has a low score, it is a very high specificity. I would just urge caution when looking at results in people where the scores may be low. I started off by showing you that 50,000 patients, 200 studies, the prevalence of depressive symptoms is in the range of 37%, 36.8%. In talking to people that are doing this in dialysis units, using PHQ-2, the prevalence of depressive symptoms, I have heard people estimate for it to be 10% or less. So there is a much lower prevalence. So one could ask the question, why is that? Is it that's research, those are selected people, and now we're doing it in the real world? The real world, the problem is not as large. I am not sure that's the explanation. I don't think that's the explanation, because in the study that we did, I showed you the results of that. We administered in that study BDI-2 in 3,000 patients. Every patient, no one was selected. And we also got 26% prevalence of depression. So if you're not getting a number that is in the order of 20% of patients screening positive, it would be important for you to reassess in how the questionnaire is being completed by patients. Patients may choose to select 0 or 1, one of the two answers, because, hey, they actually do not have a low mood. And that's the right answer then. But we also have to acknowledge that patients may not acknowledge their symptoms, or they may think that the symptoms that they have are because of their medical conditions. They're fistula clotted, they graft clotted, or they had too much salt and they can't breathe. And they may attribute their problems to their physical disease rather than their emotional burden. Some patients may not understand what the intent of the question is. Others may not want to discuss mental health issues. And finally, some patients may not have any hope that if they shared how poorly they are feeling, that they will be able to get any help. So I think it is important to acknowledge that. And if you as a clinician feel that somebody may be depressed and you give them the PHQ-2, but the score is not high, be ready to supplement assessment with other clinical questions. Don't give up. Don't give up. Say, don't believe, believe your clinical judgment is what I'm saying, and not simply the number and the score, and have them be assessed in other ways, for example, using a PHQ-9. What about a high score? You cannot treat based on a PHQ-2. So if the score is 3 or higher, the usual next step would be to do a PHQ-9. I've also heard that there are units that are directly starting with PHQ-9. They're not bothering with PHQ-2, which is fine. That is a fine approach to take, in which case there is no second step. If the score on PHQ-9 is 10 or higher, you have two ways forward. You can offer patient a treatment, or you can send them outside to a mental health specialist for additional evaluation. So what I've tried to say when talking about the diagnosis of depression, the 4 questions that I posed: which screening instrument should we use? Most units are using PHQ-2. Some units are using PHQ-9. Any of these 2 that you're using is fine. These are good instruments for us to be able to use. Who should administer the instrument? The key things that I've pointed out is usually it's a social worker. I think in terms of the skill set, they are the right personnel to be doing that. It should be administered at least once a year. I would encourage you to also administer it at the time when you're doing, for example, an unstable assessment. And be ready to help patients complete the questionnaire, because if they have barriers because of vision or dexterity or understanding, to be able to do that. How should we interpret the results? I already cautioned you to beware of low results in patients you have a clinical suspicion of depression, and supplement with additional clinical assessment. If the scores are high, 3 or higher, complete follow-up assessment with PHQ-9. And if the score is high, the next step is to assess patients' willingness to engage in treatment. I get back to this curtain again. So the first 2 steps is what we have addressed, is how to identify patients with a low mood and to diagnose depression. PHQ-2, if that's what you're doing. If PHQ-2 score is 3 or higher, do a PHQ-9. If the score is 10 or more, assess patients' willingness to engage in treatment. And the classic way to engage in treatment is what's called as the stepped care. So in people that have a high PHQ-9 score, what I'll do in the rest of the time that I have is to go through these 3 things. First is for us as healthcare workers to recognize barriers to treatment, understand the treatment options for depression, and then engage in shared decision-making to determine patients' willingness to receive treatment, and if so, which treatment and how. So those are the things that I'll cover in the remaining time that I have. So let's start with barriers to treatment that need to be overcome. And what I'm going to list likely is not going to be surprising to any of you. The first is stigma. It is, remains a huge issue for people to be willing to acknowledge that they may have depression remains extremely challenging. This is a classic study called the SMILE study that reported that most patients undergoing hemodialysis that have major depressive disorder were not interested in initiating or modifying antidepressant treatment. The second challenge is, and we can look around us, and in our community here in Seattle, the challenges are similar to likely what you can experience, is the availability of trained professionals. For prescribers, if we're talking about antidepressant drug therapy, the challenge would remain, hey, is it a psychiatrist that is going to be able to provide treatment? Should it be the primary care physician? Should it be the nephrologist? Should it be the nurse practitioner? I can tell you that there are many nephrologists. You know, the part of the challenge is that many of us that are in practice were trained like 10, 15, 20 years ago. And at that time, our training did not include training in how to treat depression, or at least treat it appropriately. And so there would be a lot of reflection that needs to happen within a community to decide in your community, with the people that you have around you, who will be the prescriber. And it would be all right for the prescriber to be different for different patients. There may be patients that have a close relationship with their primary care physician, and it'd be all right for the primary care physician to be responsible, versus another who's not seen their PCP in like 3 years, and they see the nephrologist every week, and the nephrologist may feel comfortable to be the prescriber. The challenge is even greater with regards to therapists, and we'll go through all of this in terms of the therapists and some of the different models that may exist for treatment. And then finally, reimbursement models. In the United States, dialysis is very expensive. And to add on treatment, like for example, availability of a mental health professional is gonna be very expensive. And as we know that Medicare is looking to reduce costs, not expand services. And so those are the challenges that we are up against, that we are operating within parameters of limited reimbursement, with limited comfort in people that are at the bedside in their ability to treat depression. And then we are looking at stigma and patients and barriers at a patient level that may be challenging for us to convince them that they will be helped by treatment. So I just want all of us to be aware of this. To summarize, the first question that I posed is to recognize barriers to treatment is that we have to overcome patient level and healthcare system level barriers to provide treatment for depression for patients with kidney failure. Now, there are two first-line treatment options for depression. You can have antidepressant drug therapy or cognitive behavioral therapy. And which one you choose depends upon the severity of symptoms. So this is like classifying the severity of depression based upon the score on PHQ-9. So as I said, the trigger is a score of 10 or higher. If the score is 10 or higher, it already classifies itself as a moderately severe depression, in which you can choose, if the score is between 10 and 14, you can choose either psychotherapy or antidepressant drug therapy. They are both equally effective, and in terms of what's available and what the patient's preference is, should guide the selection of that treatment. If the score is between 15 and 19, then you should consider both forms of treatment together so that you can start antidepressant drugs plus psychotherapy. And if it is severe, score is 20 or higher, drug therapy has to be the mainstay. And then you have to assess need for hospitalization, and if stable, refer for psychotherapy. So let me re-summarize. I've said this several times now. Most patients that are on dialysis that have depression will actually have scores in the 10 to 14 range. It is in that range that usually depression symptoms are. And so for most patients, the choice would be, it's an open choice of choosing between psychotherapy or drug therapy. No one form of therapy is more effective than the other for that group of patients. So let's start with drug therapy. And I'm not going to go through each one of these. I just want to acknowledge that there are a lot of antidepressant drugs that are available. Some of them are what is SSRIs, some of them are serotonin or epinephrine reuptake inhibitors, and there are these others. The biggest challenge that we have with drug therapy is that in terms of the resistance that we would face from patients is that, hey, I already take too many pills. I'm taking like 10 pills in a day. I don't want to take another pill. And then even if people agree to take the pill, if they get side effects, I'm feeling bad to begin with. It makes me feel worse. We have to know that, we have to acknowledge that, and we have to be mindful of that if we propose an antidepressant drug therapy for patients. Now, that was the master list that I put together. There are some drugs, for example, that we have to be careful in giving them in people that have kidney failure because they need dose adjustments. For example, paroxetine or venlafaxine, desvenlafaxine. So all of these drugs are eliminated by the kidneys in people whose kidneys are not working. We have to reduce their dose. But the question also is, what about research? How many of these drugs have been studied in people on dialysis? And there are only 3. And I would encourage all of you that are thinking about antidepressant drugs for people on dialysis that you limit it to these 3 drugs, because at least we have some data on their efficacy and safety. Fluoxetine, sertraline, escitalopram. Fluoxetine is Prozac, sertraline is Zoloft, escitalopram is Lexapro. I have no conflicts of interest in this regard. And of course, those are trade names. All of them, at least I know that Prozac and Zoloft are available in a generic form and are very inexpensive. I suggest you select one of these 3 drugs as default for your practice. And for me, that drug is sertraline. We use that in our research study. And if I have to use an antidepressant, my go-to antidepressant is sertraline. And I'm not advocating necessarily for sertraline, but choose one of these 3 that have at least been studied in clinical trials in people on dialysis. So that is the background of antidepressant drugs. The point here is there are many, many antidepressant drugs that are available. Some of them you have to be careful because they are excreted by the kidneys and they're not safe in people in kidney failure. And the bottom line is these are the 3 that have been tested in people on dialysis and should be in my mind, the go-to drugs up until we get more data on other drugs. What about cognitive behavioral therapy? And I am not a behavioral therapist. I'm not a behavioral scientist. But I've done research with cognitive behavioral therapy, and I understand that. And essentially, the way I've thought about this and understood this is that there are 2 words there. There's cognitive and there's behavioral. Cognitive is in the way we think affects our behavior, essentially. And people and what the purpose of this therapy is for us to change our thoughts, for us to change our behavior. So for example, in somebody who is very ill or has a lot of health problems, they may think, I can never follow all of these recommendations. I might as well give up. So those are hopeless thoughts that may result in behaviors in missing dialysis sessions. I cannot follow all of this, so I'm not going to show up for dialysis. Oh my God, you're telling me all that I need to do with my diet. I can't remember this. I can't follow this. So I'm going to eat and drink anything I want. or you've given me so many medicines, I'm just going to not take any of them. And I'm sure all of you have had patients that fall into any one of these categories. And the purpose of that therapy is to break that cycle, is to restructure these dysfunctional thoughts that results in a change in behavior. And that is what cognitive behavioral therapy is all about. It is one form of psychotherapy. It is the form of psychotherapy that is the most well studied. So moving right on, I think the important thing is that this is the study that I showed you earlier from our group, is that both those treatments work. And people may have a preference for one form of treatment over another. Just remember that cognitive behavioral therapy has no side effects. But if you prescribe a drug like sertraline, some people will get side effects. But usually they're mild to moderate, like things like, at least in our clinical trial, the symptoms people got were like nausea, palpitations, tremors, were the usual side effects people got. So this is the second point that I wanted to make in terms of understanding treatment options for depression, is that selection of initial treatment will depend upon the severity of symptoms and patient preference. Your choices are to select an antidepressant drug or a cognitive behavioral therapy. Now, moving on next, what about the principles to drug therapy? I think I've already addressed this issue, that there is going to be that tension in your dialysis unit that you'll have to sort out. Who will be the prescriber for the patient? Is it going to be somebody in the nephrology care team or outside? And I think that could vary by patient. It doesn't have to be the same for every patient. The next is that when we start antidepressant drug therapy, because I talked about the concern about side effects, the goal should be to start low and go slow. So you just have to start at the lowest possible dose and increase the dose slowly. And the eventual goal is to get to the maximum tolerable dose. And just give an example with sertraline. This is the protocol we used, for example, in our clinical trial. Recognize that the dose for sertraline ranges from 25 to 200. The goal is to get to the maximum tolerable dose. We started the dose at 25 milligrams in the first week. And if they did fine with 25 milligrams, next week went up to 50 milligrams. And then we assessed them for side effects every 2 weeks. And every 2 weeks, we increased the dose by 50 milligrams if tolerated for the first 6 weeks. And then we maintained it for another 6 weeks. So the principle is, I think the protocol for sertraline is not as important as the concept that start low, go slow. And it needs to be a trial for at least 3 months before you say this drug didn't work. What about cognitive behavioral therapy? There are, I'm going to share 3 different models for delivering cognitive behavioral therapy. The goal for these 3 different models is to provide you with the range of options for you to consider and identify which one works best for you. The model that most people operate in is what is outside referral. That means essentially it's an outside resource. It's not an individual within the dialysis unit it's somebody outside who's qualified to diagnose and treat health conditions is who you would refer them to. And that could be an in-person therapist, that could be delivered by telehealth, or it could be online. Now, the advantages of an outside referral is for a dialysis unit, it's easy to operationalize. All I have to do is to put in an order for a referral. And it's actually, it is an error. It is not the least burdensome on patients. It's the least burdensome on dialysis unit. So so the dialysis unit really doesn't have to do very much differently. The disadvantages are it's burdensome for patients. And then telehealth, we've ramped up telehealth during COVID tremendously. And we've also recognized, not surprisingly, that there's a technology gap for patients. So this is one option. One option is we're going to refer everybody outside, recognize who those outside resources are, and be mindful of the advantages and disadvantages. The second is, I think, done infrequently and rarely, would be a consultant. That means, hey, you know what? I'm in Seattle. I identified somebody in the Department of Psychiatry at the University of Washington, and I'm going to sign them up on based on a monthly fee that I'm going to give you as a consultant. Essentially a mental health provider that is in another division of the same institution or outside, available locally or online. The advantages is that, it's one person, so the dialysis unit gets to know that person, so there is a team integration. And if there's somebody who's like getting a fixed amount of payment for being available, they could be available for emergencies. But a consultant will have low capacity. Given how common depression is, there's only so much time that person will be able to devote to be able to help patients. The third is having an in-house personnel, somebody that is employed by the dialysis unit, whose job description includes provision of mental health services. And I think most people, when people think about this, think about the dialysis unit social worker, because this is within the scope of training and expertise of a social worker. That the social worker would be the one providing therapy to patients that have depression. There is one organization that I'm aware of, which is Rogerson in New York, that is actually, for which the director is Dr. Sukor, from who I've adopted these slides, that they have, he's employed actually by Rogerson as the mental health expert for all patients at Rogerson for treating depression or anxiety. Now, the advantages are, of course, it's great team integration. The patients know the social worker. It is easy for them to develop a trusting relationship with the social worker, for example, or if it's an in-house behavioral health service. And I want to be very mindful in acknowledging the workload in terms of the number of patients per social worker would need to change to allow the social worker to engage in the provision of mental health services. And then there's the additional issue of cost. So I would just summarize here that I've provided you with 3 models for providing cognitive behavioral therapy. The first is an outside referral. Send it to a therapist in the community or by telehealth or online. The second is the unit could develop a relationship with a consultant in the community that then would be responsible for available as a consultant. Dr. Smith, are you available because Mr. Jones is not feeling too good, he's feeling low. The third would be somebody that's employed with the dialysis unit. I think I have just one more slide, and I think this is what I've tried to say so far, is that the first step is to screen with PHQ-2. If the score is 3 or more, administer PHQ-9. If the score is 10 or more, assess the severity, like what's the score? What is the patient's willingness for treatment? And what will they choose for their treatment? You start treatment and then assess response and escalate if needed. I think that leaves about 8 minutes or so for questions that people may have. I want to thank May and others for the opportunity and look forward to any comments or questions from people. May, on to you.
Yes, thank you. Thank you so much, Dr. Mehrotra. That was an excellent presentation. You really gave us the nuts and bolts on how to design a program to screen for depression, the different types of treatments, what the barriers are, many of them that I think everyone's aware of, but are still formidable barriers. And the fact that programs such depression programs will be needed more than ever, not only because it's the right thing to do and there are high levels of depression, and now with COVID, even more so, but that it's going to be something that CMS is going to look at in terms of regulatory issues and how successful a dialysis unit is in meeting the needs of a patient. So please, if anyone has any questions, please write them up now and we can get to them. And maybe while we're waiting to see if anyone, oh, I see there's a question already. Let's get started. Can you see the questions, Dr. Mehrotra?
Actually not. Let me start stop
Okay.
sharing my screen, and then let's see if it shows up.
Okay.
I,
I can read them to you if you don't. Otherwise, you could just click on them and see them.
all right, let me.
Basically, you would just click on the
Now, why don't you
Q&A.
read the question? I'm just having a little
Okay, no
challenge here.
problem. The first question is there any reason not to enhance psychopharmacology with CBT at any time?
Uh, um, no. I mean, that is short. Absolutely not. I think the biggest barrier to being able to provide treatment is a patient's willingness to engage in treatment. And I think upfront, it will be important to engage with the patient and ensure that they're on board with the plan of care. And that could include, essentially, if I interpret this, combination of drug therapy with CBT. You know, one of the things that I didn't have time to address, and maybe I can use to address, we at this time do not know how long we need to treat people for. I said give a trial for a minimum of 3 months. Chances are in people that have life stressors that are ongoing during the course of long-term dialysis, that in somebody, for example, if you start antidepressant drug therapy, even if it's in conjunction with cognitive behavioral therapy, you may have to continue the drug therapy for an indefinite period of time. So it is not as if a 3-month treatment is enough, and then at which point we can stop treatment.
I was also wondering about the length of the treatment. That's very interesting. While we're waiting for some other questions, I was wondering if you think that COVID-19 has diminished some of the stigma attached with anxiety and mental health and depression, given the constant discussion about anxiety and now the frequent ads on TV, encouraging all of us to accept therapy, how to get it, and that it's perfectly fine to feel anxious during these times. Just it has really a good impact.
Yeah, no, that's actually a very, I really like that question. I don't have the answer to that. I mean, I think that's a very good point. I think that may very well be, the challenges I suspect that this could vary by socioeconomic status, that I think in terms of who's being exposed to those messages, time will tell. But I am intrigued by your comment, and I think that's probably right and gives me hope.
Another question is, are there any suggestions for motivating patients who are reluctant to attend cognitive behavioral therapy in addition to their 3 times a week dialysis?
Yeah, we, as a part of the clinical trial that we did use what we call as an engagement interview, which was motivational interviewing largely, and that did not succeed. So motivational interviewing was no better than nothing at all. I just think one of the, I don't want to minimize the value of motivational interviewing. I think it's very important. I think if we are able, in addition to help people overcome barriers, then I think people will be more open to attending CBT. So if it is, if the patient has to identify the therapist themselves and then drive to see the therapist in person, that is a significant barrier for them to be overcome. We, on the other hand, can help overcome some of these barriers. We could, we don't want to be in the business of selecting one therapist over another, but we can identify potentially a pool of therapists in the community that may be available and provide them with the list that overcomes one barrier. The second barrier that could be overcome is like, hey, you know what, particularly in this day and age with COVID, that, hey, you don't actually have to go there. We can do telemedicine for you to engage in cognitive behavioral therapy My hope is that many of these waivers that exist will persist. And the third way that at least our community, we are helping overcome barriers to telemedicine, not necessarily for this, is for example, for the dialysis unit itself to provide a device to the patient for a telemedicine visit. So that the patient is on dialysis and there is a tablet that's in the dialysis unit that somebody in the dialysis unit can bring to the patient for them then to engage in telemedicine visit with somebody else, like it's a nephrologist or somebody else. So I think most important is the issue of helping break down barriers, identifying a pool of therapists, seeing whether or not they can engage in by telehealth, and if there's a technology gap, to see whether or not we can provide them with a device and support to be able to overcome the technology gap. I see the question, is telehealth a long-term viable method? Fingers crossed. I mean, like, I wish I could say the answer is yes. I don't know. I do think that it is, you know, in the world of dialysis, Medicare was already moving towards allowing more telehealth. You know, that already, even before the pandemic, there was the waiver that had been given for home dialysis, so that if somebody is on home dialysis, you could do telehealth. Like physician visits could be by telehealth 2 out of any 3 months. So Medicare was already moving in that direction. And what I've heard is that this pressure is not going to come from physicians. This pressure is going to come from patients, because patients have recognized the convenience of getting healthcare via telehealth. So there will be a lot of pressure on Medicare not to fully roll back telehealth to the place where it was. But I think in short time will tell if it's a long-term viable method. We are leveraging it extensively. I mean, right now, you know, in the month of April and May, every one of my clinic visit was by telehealth. And even now we have something like 45, 50% of all the visits are by telehealth. Fingers crossed.
Dr. Mehrotra, unfortunately, our time is up. Thank you so much. It was really excellent, really important, and so timely, this webinar, and we thank you for your time. Please, everyone else, when you exit this webinar, you'll click on a continue button to take you to an evaluation form. If you could please complete the very short form to receive your CE credit and give us some information for future webinars. Thank you for completing it right now, and we'll be in touch for future webinars. Again, Dr. Mehrotra, thank you so much, and I hope everyone has a wonderful day.